So as I mentioned, our discussion will revolve around risk-reducing strategies for gynecologic cancer, which carries some controversial issues. Okay. So again, good afternoon, everyone. Welcome to the POGS Pre-Congress with the Society of Gynecologic Oncologists of the Philippines, entitled Risk-Reducing Strategies in Gynecologic Malignancies. And a case-based discussion. Much has been said about risk-reducing strategies, di ba? Sa mga rounds natin, sa mga clinical discussions, we mentioned the theories, guidelines, pathology, etc. Today, we will discuss cases which will focus on the options that one can consider as a reducing strategy. The utility of gene testing, medyo may pagka-high-tech, pero we will try to be very basic about our discussion. Family tree analysis o yung tinatawag nating pedigree analysis, and as well as meron tayong bonus discussion on bioethical considerations. Kasi nga magtatanggal tayo ng mga ovaryo, isa itong napakayaman na usapin tungkol sa bioethics. We will have 3 panelists who will share with us their expertise on these topics. Okay? So our learning objectives for today will be able to identify those women at increased risk of gynecologic cancer. Sino ba ang mga babaeng may mataas na risk sa pagkakaroon ng gynecologic cancer, at to be able to appropriately counsel those at high risk of gynecologic cancer. Kasi may mga may trabaho niyan, pero siguro para din meron tayong basic na kaalaman sa pagka-counsel, no? And also to screen and ano ba ang role ng mga risk-reducing surgery, at i-define din natin ang risk-reducing surgery, including prophylactic bilateral salpingo-oophorectomy and yung mga alternatives, hindi lang itong prophylactic or risk-reducing PSO, such as tubal ligation and salpingectomy. And lastly, to understand the limitations of current screening modalities for the reduction of gynecologic cancer risks. Ang format natin sa ating discussion ngayon ay live discussion. Hindi po tayo recorded. There will be 5 cases na ipipresent natin. Questions will be asked to the panelists for discussion. And also, inihikayat namin ang ating audience na magbigay ng kanilang question at sana mai-type nila sa chat box. Questions from the audience will be entertained within the discussion. And lastly, for after each case discussion, a distillation of each case will be done after every case discussion para ma-highlight natin yung mga magagandang na pag-usapan. Okay? As a disclaimer, we will not present anymore yung mga time-tested na mga risk-reducing strategies, yung mga meron ng mga napakayaman na evidences. We will go to the controversial ones at yung mga evolving theories. As well as yung mga ibibigay naming mga evidences are based on what is available now at pwedeng magbago in the future, at ngayon kung ano lang yung mga available at merong mga pag-aaral. So, let us start with the first case. Our case number 1, a 45-year-old gravida 4 para 4004 complains of pelvic pain and pressure symptoms. She still has regular monthly menstrual periods, but is no longer desirous of pregnancy. Family history is positive for colonic cancer, grandmother on maternal side. On physical examination, the corpus is asymmetrically enlarged to 16-week size. Ang diagnosis is myoma uteri. Okay? So ang guide questions natin for this case is that, number 1, how do we manage this patient? And what is the ideal surgical approach for this patient? And are there any options for this patient? Balikan lang natin ang kaso. Okay? So, ang first question natin is, what is the best surgical approach for this case? May I ask Ma'am Lulay to answer this question?
Okay. Hi, Catch. Thank you for the question. So for this patient, no, she's primarily a case of myoma uteri. She's average risk for other diseases like especially ovarian cancer. So I would recommend a total hysterectomy with bilateral salpingectomy for this patient.
Hindi ko man natatanungin kung ano kung bakit yan ang nire-recommend mo. We will deal on that later on. Ang next question ko para sa iyo ay why salpingectomy?
Okay, so as I said earlier, no, this patient, the family history is only significant for colon cancer, which is not really related to ovarian cancer. But why would we suggest a salpingectomy? Um, the bilateral salpingectomy, also called opportunistic or risk-reducing salpingectomy, is now an accepted and recommended procedure that's applicable to women in the general population. These are women na we consider average risk, no known risk factors for hereditary ovarian cancer syndrome. And we do this procedure to decrease their lifetime risk for what we call type 2 ovarian cancer. So type 2 ovarian cancer refers to the aggressive high-grade serous carcinomas which originate from the fallopian tube in most cases, but can also arise from the ovaries or the abdominal peritoneal surface. So these tumors are generally detected in the advanced stages and carry a much worse prognosis as compared to the type 1 ovarian cancers, which comprise the low-grade serous, mucinous, and endometrioid cancers. Now, studies have shown that bilateral salpingectomy can reduce the woman's risk for high-grade serous carcinoma. The oldest study we found is a Swedish population-based cohort study, which showed that bilateral salpingectomy lowers the risk by 65% as compared to just a 28% reduction for those women who just receive a bilateral tubal ligation. In 2016, Yoon et al. Published a meta-analysis and showed a 49% lower odds for ovarian cancer among women who received a bilateral salpingectomy. And the latest data that we have, and probably this is the best data that we have, is from OviCare, based in British Columbia in Canada, where they did a large population-based cohort study. This involved almost 35,000 women, and they found that opportunistic salpingectomy was associated with a lowered ovarian cancer risk. In fact, they found no cases of serous cancers in the opportunistic salpingectomy group compared to a age-adjusted rate of 5 to 6 cases in the control group.
Thank you, Ma'am Luis. So it's very clear that bilateral salpingectomy decreases a woman's risk especially for high-grade serous carcinoma. Even BTL nga, di ba? Bilateral tubal ligation can also decrease, but
Yeah.
not as much as salpingectomy. And there are so many studies, overflowing studies to confirm that, right? No? So, Teng, Dr. Ganzon, can you make, we've been mentioning risk-reducing strategy. What can you make an operational definition for the phrase risk-reducing surgery? And what are the components of a risk-reducing surgery?
So risk-reducing surgery, in particular ovarian cancer in this case, can be performed by either opportunistic salpingectomy or your risk-reducing salpingo-oophorectomy. But first of all, you have to identify the risk of your patient. Is she of average risk or is she of high risk for ovarian cancer? So what is average risk? These women have no documented germline mutation. Okay, so no strong family history as well, suspicious for a germline mutation. In contrast, a high-risk woman has confirmed deleterious BRCA1 or BRCA2 germline mutations or a strong family history of either ovarian or breast cancer. Okay? Pwedeng hindi rin siya na-test, no? Maybe this patient has had no genetic testing, which confers a higher than average risk for both breast and ovarian cancer. So in this particular case, yung colorectal cancer history, family history of this patient is probably not very significant. So she is of average risk. Okay? Determining the risk of the patient can be properly documented by performing germline BRCA mutation. Okay, so in this case, that's why Dr. Lulay said she will perform total abdominal hysterectomy with bilateral salpingectomy. The opportunistic salpingectomy is the removal of your fallopian tubes for primary prevention of epithelial, ovarian, fallopian tube, and peritoneal cancer in a woman who is of average risk. Okay, so the opportunistic salpingectomy can be performed in um, surgeries such as cesarean section, okay, or any abdominal surgery like cholecystectomy, appendectomy. You can perform your opportunistic salpingectomy. For hysterectomy, for a benign indication, you can also perform bilateral salpingectomy to decrease the risk of developing peritoneal cancer, ovarian cancer, fallopian tube cancer in a woman who is of average risk. It is different for a patient who has a higher than average risk or a documented BRCA1 and 2 mutation. For those cases, risk-reducing bilateral salpingo-oophorectomy is indicated. But you have to weigh the pros and cons. If you will perform risk-reducing bilateral salpingo-oophorectomy in a premenopausal woman, you have to weigh the risk of cardiovascular disease, dementia, osteoporosis, because they will undergo early menopause. Okay, so there is also a recommendation that you may perform salpingectomy and later on salpingo-oophorectomy in 2 steps. But that will be discussed later by Dr. Lulay as well. Okay, so in doing your risk-reducing bilateral salpingo-oophorectomy, it is always a shared decision and you should always have a proper informed consent.
Okay, thank you. Thank you, Teng. You have introduced a lot of terms, opportunistic, prophylactic salpingectomy, meron pa nga prophylactic salpingectomy with delayed oophorectomy, right? So, I have a question for you. Can you give a risk without the benefit of genetic testing?
O hindi pa siya na-test, but can we assess her risk? Okay, so ang salient feature lang naman in the family history is colorectal cancer. But that colorectal, if you look at it, it's also related to a BRCA mutation. Okay, so in this case, I know,
But
sorry.
that will be answered by
Colorectal cancer is not associated with BRCA mutation at all. Okay, so in big studies, there's no correlation between them.
by studying the family tree, pedigree history, can you give a risk already for the
Yes,
patient?
of course. Yung increased risk lang for BRCA mutation, you'd look at the history of breast, ovarian, okay, pancreatic cancer, prostate cancer in males. So, yun yung mga very significant in the family history. If those are very prominent in her family history, you would entertain a possible HBOC in this patient. Otherwise, hindi. So, of average risk lang yung patient mo.
Okay. So that brings us to the next question. Without the benefit of a genetic testing, Jay, can you answer this? How do you classify this patient in terms of risks for developing cancer in the future?
I think medyo nasagot na talaga ni Teng. I think natumbok na niya, no? The only way in this particular situation, if we examine her family history and assuming it is correct, she only has one second degree relative with a colon cancer. So it's not enough criteria to really classify her as above average, no? So I agree. I mean, with that information alone, and without the benefit of an actual genetic testing, the only classification we can give her would be average risk. So it would be unfair to just say high risk ka na just because meron kang lola na nagka-colon CA. So masyadong malaking leap yon, no? To make the patient live with the anxiety that she has a high risk of developing cancer. So yun ang limitation natin. So hanggang average risk lang talaga masasabi natin sa.
Okay, thank you, Jay. And Ma'am Lula, is there room for more conservative procedure? Anyway, this case naman, she does not like a conservative. Pero is there room for more conservative procedure such as myomectomy with bilateral tubal ligation for this patient?
Yes, definitely no. So during the informed consent process, di ba, we're supposed to discuss all the alternatives to the patient, including non-treatment, di ba? We need to tell her if we don't intervene in any manner, then you have to explain what will be the consequence of that. But also, we offer what are the other surgical procedures that we can do. So the very least you can do to address the myoma, which is causing all her symptoms, is a myomectomy. And then if she's also concerned with making sure she does no longer conceive, she has several children, then we offer at the very least a bilateral tubal ligation. So in the process, you also need to inform the patient or educate her about the advantages and disadvantages of these alternative procedures. So for instance, for myomectomy with bilateral tubal ligation, it would involve a shorter operative time, probably even less blood loss. It effectively removes the myoma and therefore relieves the patient of her symptoms. And the uterus is kept intact. Now, for some women, and I've encountered this in the clinics, some women, they feel more complete. Pag nandyan pa daw yung mattress nila, may psychological effects sa kanila yung being hysterectomized. No? May effect sa quality of life nila yon. And then the bilateral tubal ligation affords good contraception, it's permanent sterilization, and at the same time, studies have shown that BTL can decrease the risk for ovarian cancer by about 24 to 28% while maintaining hormonal function from her ovaries. The disadvantages of myomectomy for this patient would be the risk of a recurrence of the myomas, and this can be as high as 30%. And 10 to 20% of women who've had a myomectomy eventually undergo a hysterectomy within 5 to 10 years of their first surgery. And then lastly, the bilateral tubal ligation does not prevent high-grade serous carcinoma to the same extent as a risk-reducing bilateral salpingectomy would. No, as long as the bilateral salpingectomy is done properly. No, so hindi ganun kataas yung degree of prevention for high-grade serous carcinomas with a bilateral tubal ligation alone.
Yes. Pero Ma'am Lula, there are also many cases na may mga patient nagpupumilit na, Doktor, tanggalin nyo na lang lahat para wala na akong problema sa future, di ba? Saka, di ba, parang it entails a lot of explanation kung medyo nagka-clash yung inyong opinions, di ba?
Yeah, that's why patient education is very important, no? But still, you have to respect their autonomy. If the patient insists, hindi doc, gusto ko isang beses mo lang ako i-anesthesia at buksan, tanggalin mo na lahat, then you really have to explain that.
Mamaya, Ma'am Lulay, no? Yung bioethical issues, controversial issues sa bioethics.
Yes.
So, for our...
Catch, may tanong ako.
Yes.
Di sa and Dr. Lulay, I mean, do you still nagbe-BTL pa rin ba kayo, or you just advise the patient to just do the salpingectomy kung yun ang desire niya? Kunyari may gusto, like in this example, Doktora, pwedeng myomectomy with BTL. Usually, do you still do the BTL, or you just advise the patient salpingectomy na lang kung yun din naman ang gusto mo?
Personally, for cesarean section, for my CS cases, I already informed the patients that I would recommend the bilateral salpingectomy, and I would only resort to the tubal ligation if the salpingectomy cannot be carried out safely during the cesarean section. So there's always, lagi akong dalawa. Salpingectomy possible, tubal ligation. So yung tubal ligation ang possible sa consent.
Parang pareho din kami ni Ma'am Lulay sa sa kanyang
approach for CS.
Agree. Yeah.
Okay, so let us leave case number 1. But before that, before we leave case number 1, let us have a distillation. So for this first case, based on the contemporary understanding of the origins and management of ovarian cancer, we generally have an idea of the risk a patient may have to develop cancers. We may or may not have the advantage of clinical genetic testing for gene mutations. Kasi minsan, mahal yan, di ba? Mahal ang presyo niyan. So this price identification of those who are at an increased risk of inherited breast cancer and ovarian cancer. For these individuals, screening and prevention strategies can be instituted to reduce their risks. Tayong mga OBGYN plays an important role in the identification and management of women with hereditary breast and ovarian cancer syndrome. Kailangan ma-identify natin sila at ma-educate din natin. In this first case that we have presented, we saw an average risk person and we clearly delineated a risk-reducing strategy for her, which is removal of the fallopian tube but retaining the ovaries. We discussed the importance of balancing the pros and cons of removing the ovaries, its important role even in the postmenopausal period, more so in the premenopausal period. And lastly, we are advocating for correct and proper way of doing salpingectomy. May tamang paraan para gumawa ng salpingectomy. If one has to do salpingectomy, one has to perform it correctly. That's why for the next part of the discussion, let us review the art and science of doing salpingectomy and also to answer the question, naapektuhan ba yung ovarian function if we do salpingectomy? So to answer that, yung association ng salpingectomy and ovarian function, if you remove the ovaries, what will happen to the ovaries? Will there be reduction of its function? So Jay, let us talk about ovarian function and salpingectomy.
Okay, so well, there was some fear, no, before na baka pag mag-salpingectomy ka and the purpose also is to leave the ovary behind so that may ovarian function na baka the procedure itself will eventually diminish, no, ovarian function. Pero I think some data has already come out and convincingly that ovarian function does not appear to be affected by salpingectomy. So I think we're okay with that. So that fear should be allayed na. And yeah, I agree. So and there's a question, I think I'll take this opportunity to answer it. There's a question by Dr. Tirador. So is it acceptable for a residents to do opportunistic salpingectomy as sterilization or for multiparous patients, both for CS or NSDs? I don't know, but I think it's okay. I think the panel will agree, no? Yes. That they can do it if the desire is for a BTL or for sterilization. Yeah, agree.
Yeah,
as mentioned by Ma'am Lule, as long as it's safe, safely done. Yeah. Yun.
Okay.
Also,
ano nga ba yung...
add to it, even if you do vaginal hysterectomy, at that point, you can also perform bilateral salpingectomy. Kasi meron din naman tayong patients na hindi pa menopause but would have pelvic prolapse already. So that's another opportunity for bilateral salpingectomy.
Pero
it can take for other abdominal surgeries such as cholecystectomy, appendectomy, if there is an opportunity to perform bilateral salpingectomy, it's also an indication to do it at that particular time. And the route of surgery does not prevent you from performing bilateral salpingectomy. You can do it during exploration, open surgery, laparoscopy, robotic surgery, you can do it.
Yes. Ang mga ano lang kasi.
I'm sorry.
Yes,
sorry, Cacho. Go ahead.
Yeah. Mga barriers lang kasi na naririnig ko. May mga technical difficulty. Sometimes may mga May mga blood loss daw na unaccounted due to self-injectomy. Yes, Jay, you're saying, ano?
Yeah, going back to the original question. No? So I think the whole point of the principle behind self-injectomy is to be able to remove the tube completely, no, from the fimbriated end up to the uterotubal junction. And then ang sabi nga nila, you don't have to go until the interstitial portion or kung saan yung cornu, no, na magwe-wedge ka pa. Basta hanggang uterotubal junction is already, the fact that you are able to remove both tubes already significantly reduces the risk of that patient for developing ovarian or peritoneal cancers.
That is
So,
actually our next topic, Jay. Our men always tell us to do our surgeries correctly, no? Ano bang tamang self-injectomy? So, and for the sake of patient safety, which is now a hot topic these days, let us discuss what a proper self-injectomy is and how is it done. Can you answer that, Jay?
yeah, as I said, no, the self-injectomy should remove the tube completely from its fimbriated end up to the uterotubal junction. Okay, and then if in case there are, sometimes you will encounter, a lot of times actually, you'll have the fimbriated ends sometimes adherent to the ovary, and then matatakot ka to try to, I try to remove them, no, to adhesiolize them from the ovary, but if there's some fear of bleeding, kung may natira pa doon, actually ang recommendation is to cauterize those fimbriated ends that are left, adherent to the ovary.
Jay, wait, there's a question. Is there room for, in connection to the next statement that you're going to say, no? Is there room for fimbriectomy, bilateral fimbriectomy during cesarean section, where in total self-injectomy cannot be safely done?
Yes, actually that's recommended. If of course the goal is to do a complete self-injectomy, but if in your assessment it will be too difficult or it may add additional risk, no, to the patient, at least yun ang recommendation, at least be able to do a fimbriectomy. Correct.
Okay. So, yun nga, if you are going to do self-injectomy, do it properly and correctly, no? And I've lectured this already in one of those webinars. May tinatawag tayong MIST technique or MIST technique, which is mesosalpinx isolation self-injectomy. You should know your anatomy. Vascular windows are created within the mesosalpinx close to the tubal vessels. Kagaya nito. Kailangan himay-himayin mo yung mga vasculature and then try to ligate each vessel daw. And this is the MIST technique. Jay, may tanong ako tungkol sa self-injectomy, no? In the performance of total hysterectomy with bilateral self-injectomy, do you, let's say, do you isolate the fallopian tube first or tanggalin mo muna yung mattress and then balikan mo na lang yung fallopian tube after your hysterectomy?
Inuuno ko yung tubes. So I isolate the tubes, separate them from their attachments, but leave them intact, connected dun sa uterus.
Okay.
So itong maganda tong picture mo. So I would do the same technique and then just ligate those vessels until ang may iwan na lang, nakadikit na lang siya sa tube. And then I would dissect the infundibulopelvic ligament, the ovarian vessels, until dun sa where I can easily cut and ligate its attachment, the ovaries attachment to the uterus para maiwan na yung ovaries intact with its blood supply.
Let me ask Ma'am Lulay and Teng, ano yung technique nyo?
We were discussing it the other night with Jay, because he was saying na ang technique ko kasi I always use a vessel sealer para mabilis. You just seal, cut, seal, cut, seal, cut.
Yaman ka eh.
Hindi. Anyway, there's this article that he read, Dr. Famador, which says discourage yung use ng vessel sealer because you might affect the blood supply to the ovaries if you leave them. Tama ba, Jay? Anyway,
Hindi, actually, nabasa ko lang sa slide ni Cacho.
okay. So anyway,
Oo.
ang tama si Cacho have to really know your anatomy and how you can dissect or separate the fallopian tube properly without sacrificing the blood supply to the ovaries, but also hindi ka duduguin. So tama yung technique ni Catch. Madali naman yung i-identify, no? The blood supply to the fallopian tube. You can the mesosalpinx, isolate the arteries and the veins and then clamp it. If you're gonna use clamp, use the smallest instrument or the thinnest instrument or the thinnest mosquito. Do you use mosquito? Because I use the Schneeds Masyadong mosquito for me. So that's what I use, and then I isolate, and then so same with the technique of Dr. Famador up to the end, no, near the uterus. How I do it.
Yeah, my technique is very similar to what you see on the slide. I usually prefer to start at the fimbriated end as long as it's technically accessible. I've had some cases na medyo may adhesion. So, kung mas accessible sa akin yung near the uterus, I can also start there. But I usually cauterize the avascular windows and then isolate the vessels using Schneeds. And then usually a Vicryl 2O suture.
Alam niyo, iba yung technique yun. Ako ay iniiwan ko yung fallopian tube.
Yeah. Ano pa yung sinasabi mo? Tama. Yeah.
After the hysterectomy.
After hysterectomy, tapos binabalikan ko na. Lalo na pag
Binabalikan yung tube.
Yung laparoscopy naman. Then, kasi ayaw kong may nakalaylay na fallopian tube.
Okay.
Nagabal yan sa aking line of restriction or line of vision. Kaya anyway, if you have trinay ko ring hanapin kung may evidence ba saying na dapat ganito yung technique or wala pa akong nakikita unless meron po kayong pwedeng i-share sa amin na link to, or this is a very good area of research na pwede nating gawin. Ano ba ang...
So, tama ka, Catch, no? Merong alam ko yung iba, ganun ang ginagawa. Iniiwan muna yung tubes and ovaries, tapos sa kanila babalikan yung tubes. So I think kami nila, ang ginagawa namin, from the start, hinihiwalay na namin yung ovaries from the specimen. I think that's the basic principle there. So bago ka mag-hysterectomy, hiwalay mo na yung ovaries para maiwan na siya, and then the tube goes with the uterus. I think that's the there.
Until meron tayong evidence to say na this is better or that, siguro there's no wrong answer or right or
yeah, agree. I think the point is to remove the tube completely.
Yes.
Completely as possible.
Yun lang yung dun. Yeah.
And the interstitial, yun emphasize ko lang, the interstitial portion is not required for to say na complete or total self-injectomy. Okay? So, let's leave case number 1. Let's proceed to case number 2. Our second case is a 38-year-old, newly gravid, single, obese patient admitted due to profuse vaginal bleeding and severe anemia. Dugo ng dugo. This is a familiar case. Patient is not desirous of pregnancy for whatever reason. Gusto niya maging Family history showed that 2 sisters are with breast cancer. Her great-grandfather, mother's side, was reported to have prostatic cancer. So, tinamaan siya ng mga kamalasan din sa pedigree nila. So, transvaginal sonography was done at day 8 of cycle showed the endometrial thickness of 2.1 centimeters with cystic spaces and distinct endomyometrial junction. So, hysteroscopic guided endometrial biopsy showed atypical hyperplasia. Patient is then consulting you for surgical management. And sabi niya, operahan nyo na ako, tanggalin nyo na lahat. And there is no consent for medical management. May sarili siguro siyang rason. Our first question, Ma'am Teng, what are the risks of this patient to develop certain malignancies? Common to, no? Common tong case na to. When we say risk, how do we assess risks?
So, first and foremost, kung sino man yung nag-history sa kanya, I would like to commend because he was able or she was able to elicit the family history, no? Very salient, strong family history of cancer. The
Yes,
two-
kasi minsan nali-left out yan, di ba? yung pedigree history, family history.
So the two sisters had breast cancer. Those are first-degree relatives. Then a maternal great-grandfather had prostate cancer. Is that important? If you're looking at breast and prostate, more or less you're thinking along the lines of a possible BRCA1 or 2 mutation. Your patient is 38 years old, newly gravid, and obese. Phenotypically, those are not the risk factors for ovarian cancer or breast, di ba? Those are risk factors for developing endometrial and colon cancer. Now she presents with abnormal uterine bleeding, possible endometrial pathology, which we identified as a typical hyperplasia. Again, the question, are we looking at a possible BRCA1 or 2 mutation? Okay, next slide. I think I prepared something. So, with BRCA1 and 2 mutation, it is associated with hereditary breast and ovarian cancer, no? If you have pathogenic variants of BRCA1 and 2, it is characterized by an autosomal dominant pattern of inheritance. And it increases your susceptibility to breast and ovarian cancer with early onset. Fallopian tube, prostate, male breast cancer, and pancreatic cancer. Okay, next slide. For this patient, let's answer the question, is BRCA1 and 2 mutation associated with endometrial cancer? In big studies, it is not. There are cases of increased cases of endometrial cancer in patients who are BRCA1 and 2 carriers, but the absolute value or the absolute risk is very, very low. So, ang question is whether to remove both ovaries during your extrafacial hysterectomy. Ang point ko naman doon, typical hyperplasias are associated with endometrial cancer in 40% of cases. We also need to entertain other hereditary cancer syndrome in this patient, okay, such as Lynch syndrome, which we hope to tackle later on.
Yes.
Yun yung risk niya. If this patient is at risk for BRCA1 and 2 mutation because of her strong family history, ang pinakamalaking risk for her would be ovarian and breast cancer. Okay? What about endometrial? Probably not, because BRCA1 and 2 mutation is not associated with endometrial. Yun lang naman yung question na gusto kong sagutin.
Okay, thank you, Teng. So, what is the utility of the BRCA testing for this case, Ma'am Lulay?
So as Teng indicated, no, she discussed it really well. The patient's family history is significant for having 2 first-degree relatives, her sisters, who have breast cancer, and a possible aggressive prostatic cancer in a 3rd-degree relative, her great-grandfather. And all these will point to an increased likelihood of the patient having hereditary breast ovarian cancer syndrome. So in that light, then BRCA testing is warranted for this patient. Actually, ang pinakamagandang dapat magpa-test, yung dalawang sisters niya. Kasi sila yung proband, the one we call the proband in the family pedigree or the index cases. Sila sana yung mauna, pag nag-positive sila, then mas malakas ngayon yung impetus mo to convince this 38-year-old to go also for testing. No, pinakamagandang unang i-test yung sisters kung I assume they're still alive, then si patient yung magpapatest kung may mag-positive sa kanila. And then, the other utility for this patient is if she knows her BRCA carrier status, then it will help inform her better about her lifetime risk for developing breast and ovarian cancer. So, And even more importantly, it will help inform her decision on what to do with her adnexa when she goes for a hysterectomy for the atypical endometrial hyperplasia, di ba? So if she turns out to be BRCA mutation, a mutation carrier, then we need to discuss with her the performance of a risk-reducing salpingo oophorectomy at the time of her hysterectomy. And if she's BRCA negative, then the next option would be to offer a risk-reducing bilateral salpingectomy during her hysterectomy for the hyperplasia.
When we're mentioning BRCA, naalala ko si Angelina Jolie, ano?
Yes.
BRCA. Dami-daming risk reducing strategies na ginawa sa kanya. May question.
Yeah.
Can you request for yourself BRCA testing pero wala ka namang nakikitang risks?
Kahit walang family history.
Yes, gusto mo lang.
Yes, actually, BRCA mutations are not that uncommon. There are studies coming out from populations like in Canada, in the US, it can go as high as 7% in the general population, di ba? 7%. There's a move in Canada. I read one article. They're looking at making BRCA testing like a regular screening. Parang siyang pap smear for cervix. They would offer it at least once. Once lang. You only need to do it once. They want to offer it to the general public. And see, they're creating models now looking at cost effectiveness of BRCA testing for everybody. And then doing risk-reducing salpingectomy and then higher targeted screening for breast and even prophylactic mastectomy for that 7% of women who will test positive for a mutation.
I agree, Ma'am.
There's a cost modeling study going on in Canada right now. For that.
Yeah, actually nabasa ko nga yun, Doktora, when you shared that. And it was interesting, no? Kasi nga, yung gusto nilang gawin is to make the test, the genetic test, available to the general population. Well, it really comes, I mean, the earlier recommendations kasi are based on cost considerations. So masyadong magastos yung test. So they had to come up with certain recommendations or criteria on how to select kung sino dapat ang ipatest mo. So yun nga, yung family history, titingnan mo. So they had to, just to be able to be cost effective. But I think this Canadian group is trying to look into the possibility of showing that it might be even more cost-effective in the long run to really identify patients who are high risk earlier on, rather than may cancer na, saka mo palang iti-test. Parang ganun Yun yung ano nila Yeah, very interesting actually.
We're looking at ovarian cancer and fallopian tube and peritoneal lang, pero yung repercussion for a positive BRCA result also involves breast na super common in Philippines, diba? And then later on, to a smaller degree, pancreatic and prostate cancer in males. Ite-test mo rin ang male population.
Yeah.
Bigyan ko kayo ng pang-kontrabida naman. Kasi meron ding the ethics of knowing your mga future diseases. Naging hot topic din yan sa mga ethical boards. Ba't mo kailangan malaman kung ano ang mga future risks mo, ganyan. May mga ganong mga advocacies na ganyan I myself underwent, nagpa-gene testing na ako po. I myself, so alam ko na Vietnamese pala ako noon, na wala akong risk for GI pathology or GI ganyan. So alam ko ganyan. Yan yung mga advantage. Pero flip side of the coin, meron din mga ethics of knowing advocates mga ganyan. Okay? So we've been talking about BRCA, no? BRCA. So let me i-review natin kung ano ang BRCA. In order to understand further, let us take a review on what BRCA is all about. Para sa ating audience, to make it basic. Minsan kasi pag narinig mo yung BRCA, nako, highfalutin yan. Ang hirap intindihin. So let's talk about BRCA. What is the purpose of BRCA genes? Lahat tayo, everyone is born with BRCA genes. Kahit ako, kahit kayo. BRCA or BRCA stands for breast cancer susceptibility gene. Normally, BRCA genes prevent tumors from growing by repairing damaged DNA. Napaka-importante ng BRCA gene because ang tawag sa kanila ay tumor suppressor genes. Dinidetect niya at nagbibigay siya ng proteins para i-repair yung DNA, damaged DNA na yon. When DNA kasi is damaged, healthy BRCA genes will create proteins, magta-translate yan ng protein ng defense mechanism, ng repair mechanism that can help repair the DNA damage. Ang whole process na to helps maintain the stability of your cells. Okay? What happens sa mutation? Okay? We will discuss that further. Now, marami pa rin hindi just to review, gene. Ano ba ang gene? It is the basic physical and functional unit of heredity. Andyan yan sa chromosomes natin. Genes are made up of DNA, yung ACTG na yan. Some genes act as instructions to make molecules called proteins, yung translation, transcription, i-review natin yung biochem natin. Every person has 2 copies of each gene. One from father and one from mother, inherited from each parent. Most genes are the same in all people, but a small number of genes are slightly different between people. Ngayon, may natatawag namang alleles. No? Kung ang gene ay kulay ng mata, ang allele, yan yung variation ng kulay ng mata. May blue, may green, may brown, ganyan. So yun yung mga different alleles. These are small differences in their sequence of DNA bases. Now, these small differences contribute to each person's unique physical features. Okay? Now, let's talk about BRCA mutation. Bakit nagbi-mutate? Kasi may mga environmental factors, yung mga disruptors na tinatawag, endocrine disruptors, or genes na rin, di ba? So, ano bang BRCA mutations? When you have a BRCA mutation, your BRCA genes may not work the way they supposed to. Remember, sila ang taga-repair, sila ang taga-detect ng mga defects sa DNA natin. So, when your DNA is damaged, your BRCA genes, dahil mutated, can't create proteins that properly repair it. Pag walang repair mechanism, as a result, cells may grow and divide to form a tumor, putting you at an increased risk of cancer. Yan ang nangyayari kung meron kang BRCA mutation. Okay? So, BRCA mutations can be a family matter. No? Everyone carries 2 copies of BRCA genes inherited from his or her mother and father, as you can see in this diagram. Let's say yung mother, if one parent has a BRCA mutation, all of his or her children have a 50% chance of inheriting that mutation. Even if a child inherits only 1 mutated BRCA gene, that person's risk of developing cancer progresses. So anong ibig sabihin niyan? If you have an inherited BRCA mutation, your children have a 50% chance of inheriting the mutation. Your siblings have a 50% chance of having the mutation. And there's a 100% chance that one of your parents has the mutation. So I hope I have given you a very basic review of BRCA and BRCA mutations. Okay, so Teng, pag-usapan na natin, no? Let's say hypothetically, if both sisters are BRCA positive, anong next best option mo? Tinest mo yung sisters, BRCA positive pareho. What's your next best option?
Tinest ba natin yung patient? Okay. Offer the patient also to test for germline BRCA mutation. So, what if she becomes positive to either BRCA1 or 2? It will confer a higher risk status for the patient to develop either breast and ovarian cancer. How high? For BRCA1 mutation carrier, the breast cancer risk is as high as 72%, and for ovarian cancer, it's 44%. For BRCA2 mutation carriers, risk for breast cancer is 69%, and for ovarian cancer, it's 17%. Knowing your BRCA status, whether you're BRCA1, BRCA2, also will help guide you to decide when to perform your risk-reducing bilateral salpingo-oophorectomy. For BRCA1 mutation carriers, it's usually earlier. When you have completed your family size, you can do your RRBSO as early as 35 to 40 years old. If you are a BRCA2 mutation carrier, it can be much later because they develop breast and ovarian cancer much later than BRCA1 mutation carriers. So around 40 to 50 years old. Now, of course, knowing your BRCA mutation status also will guide you to regarding your risk for developing peritoneal cancer, which is as high as 1.3%. And for fallopian tube cancers is 0.6%. Okay, so yun yung the value of doing testing on this patient for BRCA1 and sagot ko ba? Okay. Ito naman, I would just like to emphasize. Kasi yung tanong, if BRCA1 and 2 confers a higher risk for developing endometrial cancer. In this study by Pennington et al., wala for endometrial cancer. Meron lang increased number of uterine papillary serous cancers, but the absolute risk is very, very low. Okay? So another study for unselected population found out that women who have uterine papillary serous cancers, about 4.6% had BRCA1 mutation, TP53, and CHEK2 mutations. Otherwise, but it is not as high, no? Yung correlation with breast and ovarian. Yun lang naman. So, okay.
Okay. Okay, thank. So, parati tayong we've been mentioning BRCA. BRCA lang ba ang ang nagko-cause ng higher risk, or are there any other genes?
Alam mo, magandang tanong yan. Kasi there are other genes that cause hereditary breast ovarian cancer. Labeled as homologous recombination genes, no? In particular, your BRIP1, your RAD51C, and your RAD51D. In fact, the recommendation, if you expand your genetic testing to include these HRD genes, BRIP1, RAD51C, RAD51D, if the patient becomes positive to that, risk-reducing DSO is also recommended for these patients. So that's very good to know, right?
Yes. So, napag-usapan na rin natin ang BRCA, di ba? Let's say nagpa-testing ka, your next step as recommended is to go for a genetic counseling para mabigyan ka ng advice, di ba? So let's talk about genetic counseling. Teng.
Okay, medyo matuguto, but it is very appropriate, and I think this will be...
I know you can deliver it in a basic way.
This is the future, and we cannot, dodge this, no? Kasama na yan dapat sa how you see your patients in the clinic. Risk assessment for female cancers once the patient comes to your clinic. And if she is at risk, how to cancel for genetic testing, no? Aside genetic counseling. So the decision to offer genetic testing involves 3 related stages. First, foremost is pre-test counseling done prior to ordering the test, in consideration of the most appropriate test to order, because these genetic tests are not cheap, no? They're very expensive. And if you ask for like a next generation sequencing, you sequence all na hindi naman kailangan, that's about 300,000 pesos. So post-test counseling also is done with proper interpretation of the results. So it is recommended that a genetic counselor, it can be your geneticist or your gynecologic oncologist or a surgeon or an oncology nurse or any healthcare practitioner who is trained in doing genetic risk assessment, no? Doing your family tree. Testing should be considered inappropriate high-risk individuals because it will likely impact the risk of management and treatment for these tested individuals or their at-risk family members. Okay, so what is a pre-test counseling? What does it entail? You have to evaluate the patient's needs and concerns regarding genetic testing. Okay, first and foremost, first and foremost, it would be her cancer risk, the benefit of the genetic testing, what are the risks and the limitations of the test that you will be asking for. Okay, so you have to perform a detailed family history, including close blood relatives, your first, second, third degree, their history for a particular cancer, types of cancer, bilaterality of the cancer, age at diagnosis, the type, and if they belong to a particular ethnicity, you have to really mention it. Aside from that, okay, you have to make a detailed medical and surgical history. Okay, did the patient have a prior genetic testing already? Does she have a personal cancer history? No, baka naman merong nagkaroon siya ng ibang cancer which will be pertinent to the development of um, this particular cancer. Like one patient of mine had had breast cancer previously. She is at risk for endometrial cancer. Aside from that, pathology reports, the histology of the previous cancer, carcinogen exposure, her reproductive history, may history ba yan ng infertility, did they have ovulation induction procedures done prior, hormone or oral contraceptive use. Okay, so that's just your pre-testing. What about the appropriate tests to ask? You have to, if the patient has a strong family history for HBOC or hereditary breast ovarian cancer syndrome, you can ask for a germline mutation, germline BRCA1 and 2 mutation testing. So how is it done? Your patient goes to the lab and then they take their blood sample or a buccal sample and a germline test is done. If your patient has had already breast cancer or ovarian cancer, tumor testing with an expanded genetic panel can be done. So what is a expanded genetic panel? You include, aside from BRCA1, BRCA2 tumor testing, you also ask for the HRD genes, your homologous recombination
Homologous recombinant deficiency.
Deficiency.
No, HRR, yeah. The homologous recombination repair genes. So you ask for that. So that's the expanded tumor testing. So how is it done? You have your tumor already, the one that you took out, submit the paraffin block, alongside with the slides, and then they do the testing. After the testing, the most important thing would be is the interpretation of results. Okay, so if you did germline BRCA1 or 2 mutation test for your patient, a positive result would of course tailor your advice to the patient whether she would undergo risk-reducing bilateral salpingo-oophorectomy later on or bilateral mastectomy to protect her from breast cancer. So those are the more or less what you can advise the patient if she tested positive for it. If she tested negative, then she is of average risk. Okay, she goes back to how you monitor women in the general population. Okay, for patients na nagkaroon ng ovarian cancer and you tested positive either for BRCA1, BRCA2, or any gene in the HRD panel, it confers susceptibility to PARP inhibition. So yun yung difference ng genetic testing. The triggers are different. Okay. Yun. So after that, post-counseling, you discuss the plan for the patient, possible management, as I've said, if you have a pathogenic or a likely pathogenic result. Now, in my practice, meron dun, minsan napatest mo, ang result, variant of
Undetermined significance.
these are mutations na hindi actionable or probably will not increase her susceptibility to the cancer that you're looking at, like ovarian and breast. So, important yun, na alam yon nung kung sino nag-ask for the test. Kasi hindi pwedeng, ano kaya ibig sabihin nito? You have to be able to interpret it very well. Now, for the tests that are available here in the Philippines, so available sila, no? There is a company that performs it. It's not cheap, but it's not also expensive. It's reasonable. Okay, you are given a voucher, and then you can check the panel that you like. Either it's germline BRCA1 or 2 mutation, or the panel that looks for the genes that are related to breast, related to ovarian, related to pancreatic cancer. So merong form yun. Okay, so yeah. So that's how we do.
Actually, meron ding may mga patient programs sa mga panels na to. They can give it for free just as your mga oncologists, mga identified oncologists all over the Philippines, kung sino yung may access nito. There's a company that offers that. And yun nga, you need to discuss the cost. I agree with the cost ng genetic testing because hindi siya medyo hindi siya mura, no? Yun. So, Teng, you mentioned about somatic mutation and ano yung isa?
Germline.
Germline mutation and somatic mutation. So may mga indications tayo dyan and what specimen you have to submit in order to do that. No?
So in germline mutation, in my practice, because we are gynecologic oncologists, the most that I would ask would be, kasi may tumor, like some ovarian cancer patient siya, I would ask for a somatic testing, the expanded somatic genetic panel, which includes BRCA1, BRCA2, and my HRD genes, because she already has ovarian cancer. The purpose of that test is whether she is susceptible to PARP inhibitor therapy later on. After your chemotherapy, you use PARP inhibition as maintenance. Okay. Now, will I do germline mutation test also in this patient? Yes. Why? If I ask for germline mutation test, if she's positive to that, it will also, it has value, no? Kung ano yung i-advise mo if she has siblings, female siblings. Baka pag may BRCA1 siya, may germline mutation, you can ask the sisters to test themselves as well. She has daughters, you can ask her daughters to be tested as well for the germline mutation. Because later on, you will advise these people who might be carriers to possibly undergo risk-reducing surgeries.
Okay.
Thank for the last lang. I'm sorry. For the benefit of the audience who may have gotten lost sa discussion, maybe before we leave the topic, just briefly differentiate germline and somatic. For the para lang kasi ako honestly nung una nalilito din ako nung una. So maybe for
So nakakalito siya pero alam mo it's doable, it's understandable. Just give time to it, no, to understand because it's very important for OBGYNs, no, even residential in genetic testing already. Germline mutation is the kind of mutation that you can pass on to the next generation. The value of doing germline mutation testing is whether, number one, kung para sa akin, no, for me, na wala namang cancer, is for me to know kung if I have a mutation, will I do risk-reducing surgery? In this case,
anong specimen sa germline para mas ma-correlate din nila?
It's blood, it's serum, and then pwede rin buccal, depende sa laboratory na gagawa. Okay. Now, if you already have cancer, breast cancer, aside from yung estrogen receptor panel mo, progesterone receptor panel, HER2/neu, which are the three basic tests before, you can add BRCA1 and BRCA2 testing. Why? Because you will, especially if you will undergo tamoxifen therapy later on. Will you do a hysterectomy, no, para to decrease your risk for endometrial cancer? Will you do bilateral salpingo oophorectomy? If you are BRCA1 or BRCA2 positive, yes, we will suggest hysterectomy with BSO for these particular breast cancer patients. Now, for ovarian cancer patients, do I test for BRCA1 and 2? Ang recommendation, iba-iba actually, pero ang sinusunod ko, for all high-grade serous ovarian cancer, you have to test. I include also women who are with the endometrioid type histology and clear cell histology. I would do the panel for BRCA1 and BRCA2 testing. But later on in my practice, I already include HRD, no, panel. Kasi para makita mo who will be susceptible to PARP inhibition. PARP inhibition medication is something that we give as maintenance. And if you give it for 2 years after your chemotherapy and there's initial response to your carboplatin and paclitaxel, it confers a longer overall survival for your ovarian cancer patients.
Yeah.
Or BRCA1 and BRCA2 mutated. So yun yung ginagawa natin. So aming specimen, di ba you have a tumor, after histopath comes out, nandun na yung paraffin block. You submit the paraffin block to the lab who will test.
Ano yung test na yun? Yun yung somatic.
This is
Yan
diba?
yung somatic or tumor.
So yung germline yung test sa either sa pasyente mismo, yung blood niya, or yung saliva. Okay.
So minsan, pag nagtitipid ka, somatic muna kung may cancer yung pasyente mo. Saka na lang pag nakaipon ulit, you do the germline for prognostic, for advice to the siblings and daughters.
There are many laboratories offering mga somatic and germline testing.
May na actually for BRCA1 and 2. But for the HRD genes, you have to talk if it's available to them. And what type of genes are they testing? Kung baka naman 3 lang yung HRD genes na tinitest, meron kasi iba, 12 yung genes na tinitest. So, isasabihin, ay, dito na lang tayo kasi mura. Pero if you look at it, konti na yung kasama sa panel.
Okay. Sige. Genetic counseling is very important, no? Referral to a genetic counselor. Ma'am Lula, since nasa province ka, ako rin.
tayo.
Nasa Berlin ka eh.
Nasa Berlin ngayon. So, anyway, sa probinsya, sa Ma'am Lulay, what do you think kung let's say meron kang BRCA result in front of you, may pasyente, anong gagawin mo?
Actually, it's not available here.
No, pero minsan,
to advise them, and then madalas naman they can go to Manila to get it done, or Cebu. Kasi there's a lab in Cebu that does it. Lately, I've had usually somatic testing kasi you only need to send the paraffin block and the slides. So that's more doable if you live in the province. So, yun lang yung papadala mo. Kasi yung buong pasyente yung pupunta ng Manila, di ba?
Sa Cebu, classmate, batchmate ko sa medicine. Anyway, there are schools. Kung gusto nyong gawa ng career planning yung hospital o yung region, meron tayo mga masters in molecular genetics sa mga no-offer ng St. Luke's or ng NIH. With that, let's go to the next question. Ma'am Lula, BRCA testing of the patient showed positive for BRCA1 but negative for BRCA2. What is the best surgical approach for this patient?
Okay, so our patient, case number 2, tested positive for BRCA1. That means she's at increased risk for breast and ovarian cancer. So, ang concern naman natin, she's going to undergo hysterectomy, di ba, for the atypical hyperplasia. So, together with that, we offer a risk-reducing bilateral salpingo-oophorectomy. We've been discussing this earlier, and it's the most effective strategy to decrease her risk for type 2 ovarian cancer. And it reduces risk by as much as 80%. So ano ba yung 80%? So we know that BRCA1 mutation carriers, their risk for ovarian cancer is more or less around 40% lifetime risk. But performing an RRBSO on the patient decreases it by 80%. So imbis na 40, magiging 8% yung lifetime risk. Hindi naman niya these are epidemiological data, no? These are numbers. But for the patient, it's significant. Pag wala na dun yung tube, wala na dun yung ovary, greatly decreased risk for ovarian cancer. It's also been found to decrease overall or all-cause mortality by as much as 77%. But there's still that small 1 to 3% lifetime risk of peritoneal high-grade serous carcinoma. Kasi iba yung cell of origin nun. Okay, it's not necessarily coming only from the fimbria. The danger or the The drawback naman of doing an RRBSO on the patient because she's young is, of course, the consequences of early surgical menopause. So for BRCA1 mutation carriers, Teng has mentioned this, we recommend RRBSO by the age of 35 to 40 years. You need to start the conversation about that procedure. For BRCA2, this has also been mentioned, you can offer it later in life at around 40 to 45. There's additional advantage that it may also reduce the risk for breast cancer because you don't have the hormones anymore. And obviously, there's the disadvantage of early onset of menopause and all its deleterious health consequences and a decreased quality of life. There are studies coming out that comparing bilateral self-injectomy versus RRBSO among BRCA positive patients, and they all say pag nag-BSO ka, mas pangit yung immediate quality of life ng patients, no? Because they're getting all these menopausal symptoms. Okay? That's why there's increasing interest in doing, if they're still young, you can just do an opportunistic self-injectomy for the patient first, and then delay the oophorectomy until later in life. Now, this is for both BRCA1 and BRCA2 mutation carriers. And these are being intensively studied. These are 6 of the studies that I found on clinicaltrials.gov. Some of these are ongoing. Some of these studies, the earlier ones, have already closed recruitment and they're just now following up their patients to look at their incidence of disease and survival. So most of these studies are non-randomized study. Hindi mo, it's not considered ethical to randomize these patients. I read through their documents on clinicaltrials.gov and they're mostly non-randomized clinical trials. So more like large prospective cohort studies. But they're very interesting. There's one study here on radical fimbrectomy. This being done in France. Parang yung bukod dun sa fimbria, tinatanggal niya yung small wedge of the ovary, kung saan nakadikit yung fimbria. So they're also doing a study on that. Trying to see if it's better than just, confining it to the entire fallopian tube. So these are the studies that are up and coming. We're waiting for their data to mature. And the very first one would be coming probably from MD Anderson, the prophylactic self-injectomy with delayed oophorectomy study.
There's a question sa chat box. No? Is it safe? This is connected to what we're discussing now.
HRT.
Yes, is it safe?
Yeah, I answered the question while you were discussing. Actually, sinasagot ko yung mga questions sa chat box.
Thank you.
Sorry. There's an ESMO guideline about that.
Let me just repeat the question.
There's some patients that you can give.
Yeah, is it safe to give menopausal HRT for such patients where we have to remove the ovaries because of BRCA positive?
Pero ang ano doon sa ESMO guideline is short interval. Just like for the first 2 or 3 years just to relieve the symptoms of menopause, but you cannot give it for a long time.
There's
no studies on that. Longer
there's
probably.
by Dr. Malig, Aya. 2018 study, 872 BRCA mutation carriers, 7 to 8 years study period, and they concluded that the use of estrogen after oophorectomy does not increase the risk of breast cancer among women with BRCA1 mutation and should reassure BRCA1 mutation carriers considering preventive surgery that HRT is safe. By this article by Kotsopoulos.
Estrogen only yung sa study, di ba?
Estrogen only yon kasi tinanggal din yung uterus.
Yes.
Question, Ma'am Lulay.
Yes.
I mean, would you recommend routinely or would you select patients that really need HRT and talagang very bad symptoms na debilitating? Or would you give the HRT for routinely, I mean, for its health benefits?
I don't prescribe routinely. I always assess the patients first, how they're doing, first few months, and then if they're not keen on doing HRT, we offer the other the other drugs. We have Blacohosh. You can try evening primrose oil, non-hormonal therapies. Pag hindi pa rin kaya, then you have to resort to the
Yeah.
HR.
Agree. I just wanted to ask kasi kung pareho tayo kasi ako personally, may fear pa rin ako to use hormones. I mean, even if all the studies are saying na it's safe, you at the back of your you're still knowing na nga na at risk yung patient. So agree, very selective, yung talagang kailangan so that the benefits really outweigh the risk. Yung talagang kailangan niya. Kasi most of the time naman patients go through it na hindi talaga kailangan ng HRT
Depends. Ako kailangan.
Yeah.
I really felt I needed it, so I'm sorry. I'm on HRT.
Okay.
So it's really up to the patient. Quality of life is really have to assess.
Agree.
Kaya important yung menopause clinic kasi talagang kailangan nila yung assessment and guidance.
Yeah.
Get the help of our menopause experts, no?
Yeah.
Yes. Let's leave this topic na, no?
Yeah.
Suppose the patient agrees to Jay, this question is for you, no? Suppose the patient agrees to undergo medical management of the atypical endometrial hyperplasia and responds well to progesterone therapy. How can she reduce her risk for ovarian cancer knowing she is a BRCA1 mutation carrier? Connected to sa discussion natin
Yeah, so disclaimer muna, no? I mean, I wouldn't advise her. I would strongly advise her to undergo surgery. Meron na siyang atypical hyperplasia, tapos lumabas pa na BRCA siya, no? Pero kung talagang, of course, we allow patients to, but if the patient really chooses and refuses to undergo the recommended, surgical treatment, and she really wants to go for medical and be very conservative, meron pa rin naman tayong may offer at least na a way to at least reduce her risk pa rin. And that would be to give basically oral contraceptive pills, oral contraception. So given the magnitude of potential benefits, so this is a statement from the ACOG practice bulletin. I'll just try to read through it quickly. Given the magnitude of potential benefits, ovarian and endometrial cancer risk reduction, pregnancy prevention, it is appropriate for women with mutations in BRCA1 or BRCA2 to use oral contraceptives if indicated, and use for cancer prophylaxis is reasonable. So this is a general statement basically for patient without any disease currently and just tested. Pero iba yung kaso natin meron na siyang atypia tapos so medyo, pero kung talagang gusto niya, ito pwede natin i-offer.
So how do you screen for ovarian cancer? Is there a way?
Okay, so yeah. So alam natin marami ng studies that have been done to try to come up with a way to screen for ovarian cancer. But again, as this statement is saying, even with women who are BRCA mutated, meron talaga silang mutation, routine ovarian cancer screening with measurement of CA125 or transvaginal ultrasonography generally is not yet recommended. So based on the studies that have been done, it's not, number one, it's not efficient and it runs the risk of either over-treating patients or doing unnecessary surgeries on them and creating anxiety. So wala pang ganun ka-effective na screening for ovarian cancer.
Okay. So let's leave case number 2. Just distillation for case 2. Yes, we presented you a patient with high risk for developing breast and ovarian cancer by way of her pedigree history. We also introduced the utility of clinical genetic testing. And let me just emphasize here, genetic counseling is recommended for all women with ovarian epithelial cancer. This includes fallopian tube cancer or primary peritoneal cancer. And for individuals who have a personal or or family history of breast cancer or ovarian cancer. Evaluating a patient's risk of hereditary breast and ovarian cancer syndrome should be a routine part of obstetric and gynecologic practice. Kaya nga pinag-uusapan natin dito para aware tayong mga OBGYN, when to refer, when to do it. Initial risk evaluation should include a personal medical history and family history. I admire clinicians who would do a complete personal and family degree history. Family degree history. Genetic testing is recommended when the results of a detailed risk assessment that is performed as part of genetic counseling suggest the presence of an inherited cancer syndrome for which specific genes have been identified and when the results of testing are likely to influence medical management. Now, women with BRCA mutations or who carry another actionable deleterious mutation predisposing to ovarian cancer should be offered risk-reducing bilateral salpingo-oophorectomy. Sa lahat ng mga nabasa ko, level B evidence yan. The timing of risk-reducing bilateral salpingo-oophorectomy can be individualized based on the particular genetic mutation, the patient's desire for future childbearing, and family history. Typically, risk-reducing salpingo-oophorectomy is recommended at age 35 to 40 years for BRCA1 mutation, as beautifully mentioned by Ma'am Lulay, carriers with the highest lifetime risk of ovarian cancer, whereas women with BRCA2 may consider delaying until age 40 to 45 years because of later onset of ovarian cancer. Now let's proceed to case number 3. This is another unique case. This case is a 48-year-old Gravida 2 para 2002 diagnosed with serous adenocarcinoma of the ovary stage 3A. So may pagka-distant spread. So family histories revealed that the father had pancreatic cancer at age 52 years, mother, colon cancer at age 74 years old, both the maternal aunts, dalawa, breast cancer. Now, the physician advised genetic testing. The patient had MSH6 positive and BRCA negative. 3 sisters, BRCA negative, MSH6 negative. And 1 sister is positive for MSH6. Parang complicated, no? What is MSH6? Paano natin i-interpret itong mga results na to? So first question for Jay, what is the most probable cause of the ovarian cancer of this patient?
Well, medyo because of the benefit of genetic testing, and this MSH6 mutated, most likely or malakas yung chance na meron na talaga siyang Lynch syndrome. And it may have been the cause of her malignancy, no?
So, what is Lynch syndrome, Jay?
Okay, we can show the next slide. Okay, Lynch syndrome, originally termed hereditary non-polyposis colorectal cancer, is an autosomal dominant multi-cancer disorder. And it is associated with a lot of other cancers, but most commonly colorectal and endometrial, no? So next slide. Yeah, this is how currently the syndrome is diagnosed, no? By identifying one or more DNA mismatch repair genes, no? Basically itong apat na to, MLH1, MSH2, MSH6, and PMS2. So this is what is tested germline to identify kung may Lynch syndrome, germline testing yan. So ang patient natin, MSH6. So ayan na, pasok na siya sa parang criteria to make the actual diagnosis of Lynch syndrome. Hindi lang suspicion, no? Diagnosed na siya. Okay, next. Sorry. The idea of the significance of Lynch syndrome, no? So individuals, we compare the risk of developing colorectal cancer in the general population, it's 2%. For those with Lynch syndrome, biglang 80% ang risk niya ng colorectal CA. Next slide. Yeah. So, again, ito naman, for endometrial cancer, for the general population, it's 1.5% risk of developing endometrial cancer. But for a patient who has Lynch syndrome, as high as 71% ang risk niya. Next slide. And then for ovarian cancer, for the general population, it's 1%. For a patient who has Lynch syndrome, 10 to 15% naman yung increase ng risk niya for ovarian cancer. And for 62% of cases diagnosed before age 50, most of them had the MSH2 or MSH6 mutations. So yun yung significance ng MH6 mutation itong patient na to. So this table just shows the what I already stated, no? How much increase in risk a Lynch syndrome patient can have for this particular cancers, endometrial, ovarian. Putol yung aking slide. Compared to the general population and how they're distributed estimatedly among age groups. So basically, I think that's it. I mean, to summarize what Lynch syndrome is, Cacho.
Yes, thank you. Very comprehensive yung basic discussion mo or on Lynch syndrome. So, Ma'am Lula, how do we monitor patients with Lynch syndrome? Kasi kanina, HBOC tayo ng HBOC. Ngayon naman, Lynch syndrome.
Okay, so for Lynch syndrome, for both men and women who have Lynch syndrome, colorectal cancer yung biggest fear, no? So for colorectal cancer screening or monitoring, a colonoscopy is suggested or recommended, and this is done every 1 to 2 years, starting at age 20 to 25 years, no? Compare that sa general population, di ba? Ang colonoscopy, you start at age 50, and then it's only once every 10 years, once per decade lang. But if you're a Lynch syndrome gene carrier, then it's done very often and very early at age 20 to 25 years of age. Now, since these women have a higher than usual risk for endometrial and ovarian cancer, then prophylactic, we need to advise them very well first about the signs and symptoms of endometrial cancer. Kasi endometrial cancer, it's highly curable because the symptoms are bleeding. So every patient who has AUB, abnormal uterine bleeding or postmenopausal bleeding, who is a Lynch syndrome patient should come in for gyne consult at once. Okay, so patient education on that symptom. And then for endometrial cancer prevention, then prophylactic to hysterectomy with bilateral salpingo-oophorectomy is recommended when childbearing is complete. But generally, it should be discussed with the patient when they reach their mid-40s. Okay? Endometrial biopsy can be done. It's recommended, although it does not, as a screening tool, wala siyang proven benefit, even among women with Lynch syndrome. However, because it's both highly sensitive and highly specific as a diagnostic tool, then endometrial biopsy is recommended or can be done. And like colonoscopy, you do it every 1 to 2 years, starting at age 30 to 35 years. So you can offer this to the patient. Transvaginal ultrasound is not recommended as a screening tool. No, it's more, mas endometrial biopsy talaga kasi mas maganda yung sensitivity niya at picking up early endometrial cancer. Now, how about ovarian cancer? Again, we educate the patient about the signs of ovarian cancer, no? Pelvic or abdominal pain or pressure, bloating, early satiety, and increased urinary frequency or urgency. There's really not enough evidence to recommend a bilateral salpingo-oophorectomy, a risk-reducing salpingo-oophorectomy for these patients, even for those with MSH6. And the decision to recommend that or to have it done should be individualized with the patient. Even the timing of doing a BSO should be individualized. You look at everything, no? Medical history niya, the complete na ba childbearing and everything. And then there's also no recommendation for ovarian cancer screening. However, there is room to recommend chemoprevention. And we would recommend the recommendation is to use progestin-based contraceptives or combined oral contraceptives, which has been shown to decrease both the risk for both endometrial and ovarian cancer. So that would be the approach for a Lynch syndrome patient.
For the very extensive explanation, holistic explanation of the monitoring for women with Lynch syndrome. Teng, both sisters are MSH6 negative. What advice can you give in terms of what risk-reducing strategy do you recommend for these MSH6 negative sisters?
Itong patient, wait lang, the sisters are MSH6 negative. So they do not have Lynch syndrome. So they are also, the three sisters are also negative for BRCA mutations. So this clearly makes them at average risk for both ovarian and breast cancer and even colorectal cancer. My question is just that, was EPCAM tested as well? So it wasn't mentioned kasi if they are negative, average risk for both ovarian and breast cancer. Actually, as I've said, there is no clear recommendation. If you just have a strong family history but the genetic testing results are negative, should you have an intensive screening? There is none. Okay, but keep in mind that other driver mutations may not yet be studied or may not yet be tested as part of the current multi-gene panel. So that's always at the back of our mind. So,
It's sort
pantay
of saying na vigilant pa rin tayo.
vigilant, baka meron pala, tapos hindi naman kasi kasama sa test.
But
Okay.
we can label the patient
Technically, oo,
as
the definitions that we have, they are at average risk for both ovarian and breast.
Mhm. Okay, thank you. And Teng,
Okay.
to emphasize what Ma'am Lula has mentioned already, what is your advice on the sister who is MSH6 positive?
Okay, so just one gene. If you're positive to just one gene out of the four that you tested for Lynch syndrome, you are already considered as having Lynch syndrome. So this patient or this sister should be monitored as such, no? A patient with Lynch syndrome that you are closely monitoring for a possibility of colorectal cancer. So colonoscopy every 1 to 2 years, starting at a very young age, 20 to 25 years, or 2 to 5 years before the onset of the youngest colorectal cancer case in the family. What about for endometrial and ovarian cancer? This was already discussed by Ma'am Lulay. So aside from symptomatology, you may recommend prophylactic THBSO as early as her mid-40s, endometrial biopsy every 1 to 2 years, medyo magastos, no? Ang question ko nga actually dito, did they classify or recommend if you can do an office biopsy, endometrial biopsy, or do you have to perform a sort of endometrial sampling under anesthesia beginning at age 30 to 35 years? Of course, chemo prevention or using progestin-based contraception or combination oral contraceptive pills is also recommended for this particular sister who is MSH6 positive. Galing no ng case na na-test nila.
Actually, etong case na to is
It's a live.
is a is a true case. May konting tweak lang. Okay, so for case number 3, we are introduced to the Lynch syndrome. Lynch syndrome, also known as hereditary non-polyposis colorectal cancer or HNPCC, is the most common cause of hereditary colorectal or colon cancer. People with Lynch syndrome are more likely to get colorectal cancer, as mentioned by our speakers, and other cancers, okay? And at a younger age, including other organs that can have cancers. We also discuss ways in which we balance or make decisions regarding genetic testing for family members of Lynch syndrome. We saw here the importance of doing genetic testing and its relevance in guiding our decisions to designing risk-reducing strategies for negative as well as positive tests or the positive germline tests. Okay, so we leave case number 3. We proceed to case number 4. You know what? As I've mentioned in one of the distillations, the timing of risk-reducing bilateral salpingo-oophorectomy can be individualized based on the particular genetic mutation, the patient's desire for future childbearing, and family history. At this point, let us talk about what are the possible bioethical issues affecting risk-reducing strategies in gynecology. Kasi napaka-common na i-connect ang bioethical issues sa pagtanggal ng ovaries, sa age, sa mga ganyan. This is best illustrated in case number 4, a very familiar case for many of us. So our fourth case is a 32-year-old, newly gravid, single, with impression of myoma uteri of 18-week size, malaki, intramural with submucous component, FIGO grade 1, and recurrent anemia secondary to heavy menstrual bleeding for the past year. So, parati siyang nagpapa-admit due to recurrent anemia. She is a member of the LGBTQIA+ and is requesting total hysterectomy. Ni-request niya, gusto ko ng total hysterectomy with bilateral salpingo-oophorectomy because takot na takot ako sa future cancers. She is also planning to have her transitioning in the near future. Okay? So at this point, case number 4 will center on bioethical considerations. So, as mentioned by the committee of Dr. Aying Blanco, yung 4-box technique, let us dissect this case using the 4-box technique. What would be the bioethical considerations? So for box 1, which is medical indications, let me ask Ma'am Lulay to discuss the principles of box 1.
Wait, so how do we approach? So box 1 means we look at the medical problem of the patient, and in this sense we applying the principles of beneficence and non-maleficence. So this patient is presenting with a large submucous myoma which is causing her significant anemia because of heavy menstrual bleeding, and the goal of our treatment is to prevent the anemia by removing the submucous myoma. And in our setting, the best way to do that would be at least a myomectomy or probably a hysterectomy. Is there a circumstance where medical treatment is not indicated? Actually, right now, we don't really have a good medical treatment for myomas, di ba? If you can give GnRH agonists, it would be a temporary measure for the myoma, but it's not going to permanently address her medical condition. What are the probabilities of success of using various treatment options? So, we cannot rely on medical management. It's just a temporary thing. If we offer surgery, there are 2 options for her. You can do a myomectomy, but as I said earlier, a myomectomy carries a 15 to 30% risk of myoma recurrence and a 10 to 20% chance of eventually a hysterectomy later in life, 5 to 10 years down the line after the myomectomy. And the next option would be yung hinihingi ng patient, which is a hysterectomy, which will turn out to be it's going to be the most effective cure for her submucous myoma. So in sum, how can this patient be benefited by medical and nursing care, and how can we avoid harm? So offering a total hysterectomy would definitely benefit her. It will deal with the myoma. She won't suffer from the recurrent anemia anymore. But what do we do with the adnexa? She's asking for a bilateral salpingo-oophorectomy. And we know from studies that while it's going to address her fear of cancer, it's also going to come with consequences because of loss of hormonal function at a very early age. So instead, we can offer her a risk-reducing bilateral salpingectomy instead. Diba? It will also reduce the risk of ovarian cancer, yung kinakatakutan niya, but at the same time, preserving her ovarian function. So yun yung different sides as to the medical indications for box 1.
Okay, thank you, Ma'am Lulay. As to the patient preferences, Teng, can you discuss this? The box 2?
Okay, sige. I'm not the best to to discuss this. The box 2 is patient preferences, where you invoke the principle of patient autonomy. So you have to answer 3 questions. Number 1, has the patient been informed of the benefits and risks, understood the information, and has given consent? Now, this is a particularly challenging case because the patient, aside from her fear of cancer, is planning to transition. So in my mind, before we convince or otherwise of performing such radical surgery at her age, there should be a multidisciplinary approach to this particular case wherein a psychiatrist should be available, your endocrinologist should be available, and of course, you, the OBGYN or GYN onco, who will perform the surgery. Okay? So, halimbawa, nandiyan naman kayong tatlo. If she plans to transition, no, to be a trans man later on and undergo testosterone therapy, the timeline of the surgery and the giving of the testosterone therapy should be very clear. Okay? Okay, so that's one way of looking at it. Kasi nga, if she plans to become a male later on, then there's no use for the uterus as well as the ovaries. Okay. Is the patient mentally capable and legally competent, and is there evidence of its capacity? So with this, again, it has to be a multidisciplinary approach kasi hindi ka naman pwedeng just one. Ikaw lang magsabi na hindi siya or kaya niyang mag-decide on her own. Has to be, documented, legally acceptable, that she is competent, mentally capable, and there is no evidence of incapacity. Now, if the patient is capable, mentally capable, what preferences about treatment is the patient stating? Okay, she has to know, of course, the pros and cons about removing both ovaries at that particular time of her hysterectomy. Okay, ang sabi ko nga, I'm not very particular ano yung function or ano yung effect ng testosterone if you give it right away. Wala bang menopausal symptoms yan? I'm not the person to be, not the expert on this. Supposedly, dapat endocrinologist, no, ang sasagot ng ganito. And I'm not sure if there have been a lot of cases already in the Philippines na nag-transition right away after surgery, no, and then testosterone therapy. Anyway, now you have to have at least, I know for a fact that you need at least a psychiatric evaluation and a psychiatric clearance for somebody who has decided to do this type of surgery, no, yung transitioning surgery. Okay? Na aside from that, yung fear of cancer, nasagot na ni Ma'am Lulay a while ago. It's just that for a transitioning person, has to be a multidisciplinary approach, and the psychiatric evaluation and psychiatric clearance has to be there. Okay. So yun naman.
Okay, thank you, Teng. So for box 3, this illustrates quality of life and invokes the principles of beneficence, non-maleficence, and respect for autonomy. There are 3 questions to guide us, no, to assess quality of life. What are the prospects? First, what are the prospects with or without treatment for a return to normal life? And what physical, mental, and social deficits might the patient experience even if treatment succeeds? That is a very important question. Either myomectomy, kahit naman myomectomy or hysterectomy, it would clearly benefit the patient. A risk-reducing bilateral self-injectomy would alleviate fear of cancer. But RRBSO, or risk-reducing bilateral salpingo-oophorectomy, would be deleterious to her overall future health since she's only 32 years old. And as mentioned in the discussion by Ma'am Lulay, maraming effects yan kapag nagtatanggal ka ng ovaries at a very young age. Second question, are there biases that might prejudice the provider's evaluation of the patient's quality of life? This will depend on the mindset and beliefs, convictions of each practitioner. May iba-iba tayong mga pananaw sa may mga prejudice tayo. Yung oncologist, merong siyang prejudice. Yung endocrinologist, may mga prejudice yan. Some practitioners' religious beliefs, for instance, may lead to prejudice and make them doubt the patient's motives in requesting for a PSO. during the surgical management of her myoma. Ang question, is it really fear of cancer? Or is it her desire to transition into maleness by removing her female hormones? So this has to be evaluated. And lastly, under box 3, what ethical issues arise concerning improving or enhancing a patient's quality of life? Either myomectomy naman or hysterectomy will definitely improve her medical condition, with benefit clearly outweighing the risks. However, ang risk-reducing bilateral salpingo-oophorectomy in this female who is only average risk for ovarian cancer is a situation where risks of early menopause likely will be greater than the benefit. Yung harm is greater than the benefit. Okay? So for the box 4, let me request Ma'am Lulay to elucidate on this.
Okay, for box 4, we're looking at contextual features. So this invokes the principles of justice and fairness. Parang ito yung pinakamahirap dun sa 4 boxes kasi you're going to look at all the things that are surrounding the patient now. This is not just between patient and doctor. We want to know ano pa yung ibang factors that are can impact the patient's decision and the outcome of treatment. So, number 1, meron bang professional or business interests that might create conflict of interest in the clinical treatment of the patient? So, as far as I can see, mukhang wala naman, no, for this patient. There seems to be no apparent conflict of interest from a professional viewpoint. Are there parties other than the clinician and the patient, like the family members, who have an interest in the clinical decision? So, considering yung sa kultura ng Pilipino, no, we have very close family ties, it may also be prudent to ask the patient how her family feels about her decision to have a hysterectomy and, more importantly, to have the bilateral salpingo-oophorectomy. So, supportive ba yung family niya about her decision, or are there, conflicting opinions? And how is she being affected by this? Are there financial factors that create conflicts of interest in clinical decisions? So, ito minsan you see this, di ba? There are some patients na pag magpapa-opera sila, syempre it entails cost. There are usually my family members who would offer to assist them or help them financially to cover the cost of their treatment. So, we need to probably know about that also. Will there be conflicts with family members who may be helping her financially for treatment regarding her request for THBSO and future maintenance therapy if she goes into early menopause? Okay. Number 4, are there problems of allocating scarce health resources that might affect clinical decisions? So, siguro ito matunog kung service or charity patient siya. No? Kasi government, yung government funds yung gagamitin mo for her treatment, is it justified to use that? Definitely for the hysterectomy, yes, no, because she needs to have a hysterectomy. But the question is about the bilateral salpingo-oophorectomy. But if you look at it, hindi naman malaking add-on na cost for care yung bilateral salpingo-oophorectomy. In terms of the surgery, it adds only a few minutes. It doesn't entail a lot of blood loss or complication rates. No, both RRBS and RRBSO. Pero kung ang usapan is about her maintenance medication, will she be asking for financial assistance for that? Then that's also an ethical question in terms of justice and fairness. Are there religious or legal issues that might affect clinical decisions? So, naman sa Pilipino din, no, religious issues can weigh heavily on the patient's decisions and even in the healthcare provider's decision to take care of the patient. So that may come into play also in this case. But in terms of legal impediments, as long as the informed consent process is followed and well documented, I don't really see any legal impediments that will arise that are pertinent to this case. And then lastly, are there conflicts of interest within institutions or organizations or hospitals that may affect clinical decision and patient welfare? So again, I don't really foresee any conflict of interest pertaining to institutions for this case.
Okay, so thank you. Since tayo, ang residence training program natin, transitioning to bioethics, integration of bioethics into the curriculum, we have given you a very beautiful illustration. So, actually, eto, napakagandang discussion natin for a 4-box technique that you can use, our dear residents, for your discussions. Okay? So, this to distill, once the details of a case have been outlined according to the 4 boxes or 4 topics, there are a series of questions that the clinician should ask. Now, what is at issue? Ano bang issue? Ano ba ang conflict? Where is the conflict? Conflicting opinion between the patient who is requesting for ang gusto niya, RRBSO together with total hysterectomy, and the doctor who knows that RRBSO at such an early age will lead to increased risk of disease and mortality for the patient. There is clashing of decisions. No? What is this case of? Ano bang kasong to? Does it sound like other cases you may have encountered? Case is a conflict in the doctors observing the principles of beneficence. Ang example dyan is suggesting a procedure like RRBS or risk-reducing bilateral salpingectomy to decrease ovarian cancer risk, and non-maleficent, suggesting not to resort to risk-reducing bilateral salpingo-operectomy as per patient's request due to its known deleterious effects, versus yung gusto ng patient, yung patient preference, the patient's right to autonomy. It is important for the physician, lahat tayo, OBGYNs, to do his or her very best to educate. Okay? Nandyan tayo para i-guide yung mga patients natin, para i-educate natin sila, para timbangin ang pros and cons, to inform and convince that the patient of the best surgical management for her case. Okay? So it's a very beautiful case number 4. So for our last case, case number 5, parang ano to, parang synthesis of what we have learned so far. This is a 22-year-old G0, single, female, consults your clinic due to recent onset dysmenorrhea of increasing severity over the past 2 years. Menarche was at age 13 years old. Transrectal ultrasound revealed bilateral endometriotic cysts, 5 centimeters in widest diameter. Family history is remarkable for endometrioid adenocarcinoma of the ovary, stage 2B, in maternal grandmother. Died 1.5 years after initial diagnosis despite surgery and chemotherapy. So meron siyang family history nga. No? And also endometrioid adenocarcinoma ovary, stage 2B in maternal aunt, diagnosed at age 35 years. Currently in remission 2 years after debulking surgery and chemotherapy. So meron siyang dalawang case sa family history. Question for this is there a risk for HBOC, hereditary breast ovarian cancer, in this particular family? So Ma'am Lulay.
Yeah, so based on the ACOG Practice Bulletin for Hereditary Breast and Ovarian Cancer, the presence of any non-mucinous ovarian cancer in the patient's maternal aunt and grandmother places her at increased likelihood of having HBOC. No, as long as even if it's endometrioid, it's considered a significant point in the family history. Hindi lang serous carcinoma yung concern. And it has been shown that 9 to 24% of all epithelial ovarian cancers are due to BRCA germline mutation. So for this particular patient, it's important that her aunt, the one who's still alive and is in remission from her ovarian cancer, should be encouraged to undergo genetic counseling and testing for germline mutations so that she can better inform the family's risk for future cancers, especially for this very symptomatic 22-year-old niece of the patient, who's consulting you in the clinic.
Mm-hmm. So, best risk reducing strategy for this case. Jay, can you talk about?
So it's similar to the case earlier, no? So ang pinakamagandang risk-reducing strategy for her was to advise her to go on oral contraceptive pills at this early age in her life, no? So as we discussed earlier, oral contraceptive pills can reduce the risk of an average, even average or more so, this possible suspect of having a syndrome. So oral contraceptives can be advised to help mitigate or reduce the risk of developing ovarian cancer in this patient.
Okay, thanks, Jay.
Yeah.
Ma'am Lulay, about what you mentioned about risk-reducing self-injectomy with delayed oophorectomy or what sa ACOG tinawag nilang PSDO.
Yes.
Can you elucidate on this?
So for our particular patient, no, so this patient is consulting you. Let's assume na the aunt was still unable to get tested for possible BRCA mutation. So how do you address the patient's concern? No, she's really concerned. Doc, baka yung mga cyst ko maging cancer in the future, di ba? So aside from dealing with the endometriosis of this patient here and now, no, you offer treatment for the endometriosis to relieve her of her symptoms and to prevent future complications from the endometriotic cyst itself. When she gets older and she has achieved her desired family size, it would be prudent to offer her risk-reducing bilateral self-injectomy or at least a bilateral tubal ligation, both of which have been shown to be effective in preventing adenocarcinoma of the ovary. There's also an option to offer delayed bilateral oophorectomy. This can also be discussed with the patient kahit na hindi siya nakapatest for BRCA. But again, because you don't have the strength of indication of a documented genetic germline mutation, you really need to discuss with her the risk-benefit assessment and look into the age, her comorbidities, and her clinical symptoms at the time that you're having this conversation about delayed oophorectomy. And you can also emphasize the screening for breast cancer itself. Again, may dilemma ka, no? Kasi iba yung breast cancer screening pag general population, iba yung breast cancer screening kung BRCA mutation carrier siya. No? So, dapat aware yung patient and na-discuss to sa kanila. Ideally talaga sana mas maganda kung makapatest yung aunt niya na merong endometrioid ovarian CA na ngayon. Okay.
Or, doktora, pwede rin siya mismo magpa-test kung talagang concerned siya. Because I agree with you, no? Yung any surgical intervention in this young patient, she's only 22. And then to go to that extra step of at even doing a bilateral self-injectomy in her has to be justified at least with some clear evidence that she has the mutation and she's at risk. So far, ang meron tayo is a strong suspicion that she has it because of her family history. But any aggressive intervention at especially 22 lang I think the prudent thing to hear is to advise her if she is entertaining that possibility and that fear and she is maybe requesting for some form of intervention surgically, then the best thing is for her to get that genetic testing done. I think that even for us doctors, that's the safest thing to do rather than to ang pinaka simple sa kanya at her age would just do the OCPs unless magpa-test siya at lumabas talaga na meron siyang mutation na BRCA. Yeah.
Okay. So, Teng.
Yeah.
What about intensive screening?
Monitoring patient.
Ulit?
Okay, so intensive screening for ovarian cancer is getting your serum CA-125 and a transvaginal ultrasound siguro mga every 6 months or months. This is generally not recommended both for average risk and high risk women. Why? Because they found out it does not improve survival if you do intensive screening for ovarian cancer. There's no benefit for overall survival if you do it, no? There was one patient they observed in one study. Um, she underwent every 6 months serum CA125 and transvaginal ultrasound, no, religiously, but developed advanced ovarian cancer after 4 years in a BRCA1 mutated patient. So even if you are being seen regularly, it does not confer a protection against ovarian cancer if you are seen and monitored as intensively as that. So it's not recommended.
Okay.
But the patient should be advised genetic counseling and testing in the light of her family history to determine if she is at high risk for ovarian cancer. So I recommend a germline BRCA1 and 2 mutation test for this patient. That's what Jay has said already. Yun lang.
Thank you. Currently, the most effective way to lower the risk of ovarian cancer in BRCA mutation carriers is through bilateral salpingo-oophorectomy, without any doubt. Unfortunately, due to decreased circulating estrogen, it is linked to considerable short and long-term morbidity. Alam natin yan from the discussion, from the literatures. The evaluation of less morbid options, kaya nga may mga studies offering less morbid options, has received a lot of attention recently, particularly prophylactic salpingectomy with delayed oophorectomy, yung PSDO, and multimodal cancer screening, yung mga screening scoring systems. Now, in order to inform the counseling given to BRCA mutation carriers on this complex topic and to encourage future research to make it easier to incorporate such alternatives into standard practice. So it's an evolving science that can augment our clinical practice later on. No? Intensive screening and prophylactic salpingectomy with delayed oophorectomy are the two main alternatives to reducing BSO that are currently being investigated. The use of oral contraceptive pills, which are currently advised as a viable adjunct measure, and other candidate medications are included in the chemo prevention, a third area of investigation. Future BRCA mutation carriers may be able to postpone oophorectomy without risking their safety thanks to two methods that are now being researched. So being researched pa yan. The evaluation of prophylactic salpingectomy with delayed oophorectomy has finally moved into a practical phase, which will clarify the many uncertainties surrounding its therapeutic efficacy. Several prospective studies are currently being conducted in this area. As mentioned by Ma'am Lulay, marami ng mga magmamature na yung mga yan. In terms of surveillance, new developments utilizing algorithmic treatment in postmenopausal women, while debatable, call for more research in the high-risk population. Until more information is made available, the only preventive actions that are still advised for BRCA mutation carriers to significantly lower the risk of ovarian cancer are risk-reducing bilateral salpingo-oophorectomy and oral contraceptive pills. So that ends our 5 cases. Ang dami nating natutunan, and ovarian cancer, just to end our session, ovarian cancer of this yung session of the case-based applications. Ovarian cancer also refers to hindi lang ovarian cancer, no? It refers also to fallopian tube cancer and primary peritoneal cancer in this context due to its current understanding of the causes and treatment of ovarian cancer. Clinical genetic testing for gene mutations enables more accurate identification of women who are more likely to develop ovarian and breast cancer due to inherited factors. There are strategies for screening and prevention that can be implemented for these people to lessen their risks. Marami yan, as beautifully discussed by our 3 experts in the panel. When it comes to identifying and treating women with hereditary breast and ovarian cancer syndrome, tayong mga obstetrician-gynecologists are very crucial Kung nakinig kayo, marami dapat kayong natutunan at pwede nating i-apply sa clinical practice natin. A referral to a genetic counselor, gynecologic or medical oncologist, or other genetics specialist should be taken into consideration if an OBGYN or other gynecologic care provider has the essential knowledge or competence in cancer genetics to counsel a patient appropriately. So there are new methods being developed for genetic testing, and more genes are being found that confer variable risks of breast cancer, ovarian cancer, and other types of cancer. So here are our references, mga references na ginamit lahat ng ating very credible members of the expert panel. So that's all the time that we have for the discussion. I would like to thank our panelists, Ma'am Lula Tupas, Dr. Teng Ganzon, and Dr. J. Famador for sharing your expertise and insights. This has been a very informative session, and me as a host and moderator, I learned a lot. So as